Hi, and welcome to Something to Talk About. I'm LICSW, and for the next hour, as you saw from our introduction, we're going to be talking about mind-body health. Plus a little bit more detail than that, but I didn't want to give away too much in the introduction. Before we begin, I want to thank everyone for tuning in. You can always email me at talk@bcattv.org if you have a suggestion for a future topic, or if you miss our wonderful guests' emails and you forget, and I can get to them. I would like to thank the crew for this evening. We are not live, so Tad Stefanak is helping us out. He's a staff member here, making sure us volunteers get everything off the ground smoothly. I would also like to thank Christina Nikitas and Gwyneth McNamee for giving up their evening to come to BCAT and help get the show underway. So thank you both very much. My wonderful guests, you might remember because they have been here before, just not together. We have Amy Colozzo, who's a licensed social worker?
Correct. Mm-hmm.
Okay. But you are a perinatal postpartum grief and loss specialist.
Yes. Quite a mouthful.
That is a mouthful. And you get paid per letter. No.
If only.
And Amanda Holmes?
Yeah. Yep.
Okay. Who you work for Integrated Gastroenterology Consultants.
Yes. Yes, I work.
And you have a bunch of initials after your name, but I'm not sure what those are.
I work for Integrated Gastroenterology. I'm having a pronunciation problem. I work for gastroenterologists, but I also work for Orthopedics Plus Physical Therapy in Bedford, Mass. as well.
Okay. Mm-hmm. Curious to see how those two fit together.
Yes. Yep.
Well, before we get into your specialties, although the question I'm about to ask is kind of your specialty, can you tell us a little bit about yourselves, where you grew up, how you came to the Burlington area, and what made you go into the fields that you're in?
Sure.
Go ahead.
All right.
I just can't imagine somebody in kindergarten going, Mom, I want to be a gastroenterologist. I can't even say it. So, okay.
So I'm originally from California. I grew up there. I went to college and grad school out there. I met my husband out there, though he's originally from out here, Arlington. And we had our oldest daughter, Emma, when we were still living in San Diego. We moved here a year later, so we've been...
Ooh. Yep. Moving with a toddler. Ooh.
Yeah, but we survived it. So we moved out here in 2014 and settled in the Burlington area. Then we had our second daughter when we were living here in Burlington. I've always worked within this field of social work, doing a number of different things. I worked in hospitals, I've worked with addiction, in outpatient therapy, and I branched off into my own private practice shortly. My youngest was about 2.
Okay.
And what drew me to the postpartum world was my own experience with perinatal mental health and lack of awareness and really difficult challenges after I had my younger daughter. And even as a mental health professional, I was pretty caught off guard. And so my
because it's not going to happen to you.
Right, right. So after some deep soul searching and lots of good support and treatment, I have shifted my focus, and I specialize in perinatal mental health. I have a certification. I'm very involved with Postpartum Support International. I volunteer here with our local Massachusetts coordinator, and I'm also on the board.
Wow. So. I didn't know any of that existed, so I'm glad you're here. Where were you in 2010 when I needed you?
Yeah.
Figuring out my way.
Yeah.
Actually, you were still out in California.
I was,
you know.
yeah. So that's my story.
Okay. It's a very good story.
Thank you.
Thank you for what you do.
Thank you.
So I've been a physical therapist for 23 years as of this past September 8th, 23 years, a licensed PT, thank you. And I went to Northeastern University for my undergrad and my master's, and I went over to Australia to the University of Melbourne to become certified in pelvic floor incontinence rehabilitation.
Okay.
And then from Australia, I went out to Chicago to work for a little bit, and from Chicago I went over to England to work for the national healthcare system and their private healthcare systems. And I was able to continue my pelvic floor rehabilitation specialty. And I came to Burlington in 2014, and I worked for a few different other places before then, and I'm in integrated gastroenterology for a few years now, and I'm doing private work at Orthopedics Plus Physical Therapy in the specialty of women's health, men's health, as well as pediatric bowel, bladder, and pelvic pain.
Wow.
So I like to see the adolescents. I like to see teenagers, which I can see in Bedford.
Oh, cool. Now, just curious, you know, tangent number one, we're going to lose track of tangents.
Yeah.
Australia and England.
Yeah.
Why did you find that you had to go overseas? Is it because
Yeah.
that subject was more
Yep.
developed?
Yep, we didn't even have a postgraduate certificate here in the United States when I was seeking to do it.
Okay.
And the Australians are known for their research. They definitely get more funding from the government to do research in the hospitals and in the clinics. So I wanted to go where the best research was for physiotherapy, but also for my specialty of pelvic floor.
Okay.
And their postgraduate program was established. More so than anything what we had here in the U.S.
And it's still like certifications?
Yeah, the Australians get a lot of credibility. When I worked in England, an Australian would definitely beat out an American when it came to an allied health job, like a physiotherapy job.
Okay.
They're highly esteemed and revered.
Wow.
Around the world, especially in England. The Queen of England, God rest her soul, would fly in an Australian physiotherapist for her back pain.
Wow.
Yeah.
That's saying something about
Yeah.
Australia's medical system. That's pretty, or at least their training.
Right. And there are a huge wait list in the national healthcare system, as you can imagine. When I went over to England, there was a 9-month wait list for me. 9 months of patients.
Wow.
Right. And excuse me, if you didn't have the money to pay for a total hip replacement, you have to wait for a certain age in the national healthcare system to have your total hip replacement.
Oh, wow.
So I would have people like maybe 50 walking in with bilateral canes, both hands, osteoarthritis of both hips, but the national healthcare system was not going to pay for them to have their hip replaced. Whereas here in America, it would happen like in your 30s. You know, I have patients that young who are having joint replacements, unfortunately.
Yeah,
But
I don't know if I'd want to be 30 and need, you know.
But if you're at high risk for falling and it's going to affect your other joints, and it's affecting your quality of life, maintaining a job, taking care of children or an elderly person in your life, you got to get it done. And you have to go for proper rehab and not be on a wait list for that.
Especially a 9-month wait list.
Right. But they are revered over there for the research. I mean, we follow the British Journal of Medicine. They do more research than us. And when I worked in England, the Australian physios would say to me, you know, we always hear about what Canada's doing, but we never hear about what the American physios are doing. I'm like, well, we're not producing.
We're not doing anything.
We're getting those patients in the door. We're treating those patients and taking care of them. We're not being paid to collect data.
Oh, okay. Got it.
Yeah.
So, perinatal health and postpartum health, can we like define the two of those and how much do they overlap?
Yeah, so perinatal mental health is kind of the umbrella term that we use.
Okay.
And perinatal would be, you know, anything from conception to afterwards. And so postpartum is obviously after birth.
Okay.
And so people can be diagnosed with a perinatal mood disorder, which would be when you're, you know, during your pregnancy. And then postpartum would be after birth. I think it's also important that we do a lot of kind of the big umbrella term that I use personally is reproductive mental health, because it kind of captures preconception planning, fertility, the grief and loss world, versus like really being minute about perinatal pregnancy or postpartum after birth. So that reproductive mental health captures the whole family planning period.
But for tonight, would you guys be comfortable if we just focused on the women's side?
Yeah, of course.
Because I think that'll be enough to talk about.
Yeah.
So how are pelvic floor issues related to postpartum?
Right. So we'd like to get our patients referred to us before the 3rd trimester. Between the 2nd and 3rd trimester, I would love to see my women's health patients, my OBGYN patients, so we can start going over the strengthening program at that point.
Does it really impact women that early in their pregnancy?
Yes, we want them to have a successful delivery,
Okay.
and we want them to be able to bounce back during that 4th trimester. And we know that it's very hectic to get to appointments, and it's very stressful for women's health patients when they have a newborn baby at home. Most women just don't have the support, you know, whether they're, you know, middle income or higher income. There's just not a lot of people there to support the woman. So I encourage, you know, all my female patients, postpartum patients, bring the baby with you. If you feel comfortable doing that, bring the baby. We'll try to get something done. You know, you're with me in a closed room, you know, there's no one else around us. So if the baby's, you know, not vaccinated or you're afraid of COVID and germs, the baby is safe in our treatment room. And we'll do what we can. We'll accomplish some exercises. I'll try to get some manual therapy in with you. Maybe we'll accomplish some biofeedback training and some other therapeutic modalities so you can see what your pelvic floor muscle is doing and not doing, what you need to work on at home. And I try to make it functional because it's so stressful to tell someone to do exercises when maybe they got they had 2 hours of sleep last night, you know.
And the whole sleep when the baby sleep thing, that just doesn't.
Yeah, and, you know, I tell my patients, you know, let's just start with functional. When you sneeze, cough, and laugh, tighten that pelvic floor muscle, contract that pelvic floor muscle. You feel that sneeze coming on, squeeze. If you feel like you can't get it, cross your legs like I am right now. That's going to facilitate the pelvic floor muscle contraction. So just be aware you're trying to brace and bring those pelvic floor organs up and in, and explain to the patient we don't want those organs to fall out. You don't want a prolapse, a pop, a pelvic organ prolapse. Okay, we're trying to keep everything up and in as you go through this 4th trimester where you're getting weaker as we go along here. You're not getting enough sleep, and you're not able to do a ton of isolated specific strength training. Telling that women's health patient to contract her abdominals, pelvic tilt, every time that she lifts the baby out of the crib, on and off the changing table, in and out of the car. So just different body mechanic cues to get them through those first few months of motherhood.
Yeah, and the connection's huge, and I love all my clients to see pelvic floor PT during pregnancy, to have that established relationship. And the connection between, when you think of your mind-body connection, if you're in pain, your mental health is going to suffer, and you're already at such a vulnerable period postpartum. You're not sleeping, there's huge, you know, your family dynamic has changed.
And the hormone levels are just all over the
everything.
place.
And we know that, you know, typically for many parents, you know, mom's health gets kind of pushed to the bottom of the priority list. And so you're doing a lot of newborn check-ins, and you're focused on baby sleep, and you're focused on baby's feeding, and mom's own recovery tends to not get as much attention, you know, culturally as we would like it to, and especially being able to get the referrals in to see somebody during pregnancy. I love all of my clients to be able to see pelvic floor before, even people, because I'll have people come in and say, well, I'm going to have a planned C-section, why do I need to go? But it's so important because everything is getting moved and pushed and changed down there.
Your bones are turning to rubber when you...
It's very complicated. Like I can't believe, like, all the women, they come in during their pregnancy, they're flying on planes for their jobs. I mean, they look exhausted sitting in their chair talking to me. I'm like, we'll try to put something together here, but you got to get your rest at night. And that's what the postpartum period, like, I feel like I can't even ask you to do anything until you start sleeping better at night. And so I'm all about the sleep consultants, and I tell everyone, you know, when they get married, when they're in a prenatal period, I'm like, start saving some money for the basics. Like, don't feel like you can't hire a sleep consultant, a sleep trainer, you know, who's been recommended to you, and be able to see us during the pregnancy so that we've developed the conversation and some guidelines for how we're going to get through the postpartum period and be successful. We're here, it's already implanted, what's happening.
Couple of unrelated questions. How do you get somebody to be referred to you? And then I already forgot the other question.
I'm going to let you answer that, and then I'm going to answer it.
Sure. So in an ideal world, world or how it really works out?
Right.
How about both?
Right.
How would you like to see it happen?
I think our
and what's
answer's the
reality?
same.
Right. I mean, I
Sadly.
have many thoughts of how I wish our system was set up to support birthing families in terms of complementary wraparound care services. So in an ideal world, everybody would have access to a therapist and a trusted provider, medical provider, and a pelvic floor PT and sleep consultants and food and housing. All of those would be wrapped
Without
around.
a 9-month wait list.
Right. The reality, so a lot of people will self-refer if they're starting to feel, maybe my mood is off or I'm really anxious during my pregnancy. I have a lot of referrals from OB offices directly, from hospitals kind of after birth. I'll see my clients from there, Postpartum Support International. So I think one benefit is I think that perinatal mental health and postpartum mental health has been much more talked about than it used to be. So there's a lot of celebrities talking about it, and I think that gives really good attention. So people will hear, oh, well, if so-and-so struggled, maybe it's not, if they can struggle and get help, it's not just me.
Right.
So Postpartum Support National has a fantastic helpline. Anybody can call in for resources. There's a 24/7 maternal mental health crisis hotline. So all of those extra supports will then kind of get funneled. So I like to think like from the macro down to the micro. And that's kind of how people end up at my office. And if they're not usually seeing pelvic floor PT, it's one of in my initial assessment, I'm always talking not just the mental health, but sleep. Sleep is the biggest thing I talk about all day long. And then also, how are you taking care of your physical body? Where are you hurting? Where are you, where else can we help get you support?
And I'm also realizing, you're mentioning sleep, but what about eating too? Because that's like really important.
Yeah,
'Cause
sleep.
you're too busy doing everything else.
Yeah,
and
sleep, eating. I'm a big proponent. I talk a lot about making snack stations around the house.
Yep.
So wherever you're feeding baby, making sure that you have something accessible, making sure you have water bottle with a straw. It's always getting filled. And then different snacks all around the house.
Kind of like that idea.
I know. I mean, I like to snack all the time, as it is now.
And that's another thing is, in that prenatal period before the baby shower, if your family does baby showers, getting prepared meal kits, for those first few months where you're trying to figure out a schedule at home. I think that's a good financial investment. It's hard, and the husband is affected by it. I mean, this is life-changing for the husband.
Yeah.
And everyone has different relationship dynamics, and you just hear that a husband is used to his partner doing A through Z, and then the baby comes into the picture, and A through Z isn't getting done anymore.
Yeah.
And the mother is becoming very frustrated and needs to learn to become more verbal.
Yeah, and so a lot of times I'll talk about I like to do postpartum planning checklists with my clients. So before birth, and so a lot of times what we talk about too is, because a lot of people will say, oh, how can I help? What can I do? And many people, I'm guilty of it too.
Laundry.
I'm fine, I've got it. Versus we talk about sitting down with your partner and making this checklist of, okay, if somebody asks, what can they do? What would we put on it? Laundry, do the dishes, wash some bottles, throw a load of laundry, fold some laundry, write it down, put it on the fridge. Then when people are coming and visiting and they want to hold baby, oh, pick something off the list. Here's what you can do. That village mentality, we don't have as much in our culture, in our society right now. And, women.
It's not that we don't want to, we just don't have that awareness.
Or some people just don't have the village too.
That's true.
And so I think that's a big part of why women's mental health and physical health suffers, because there's just not, the supports aren't in place.
Okay.
And we could go on tangents forever. Parental leave,
Well, I get
all
upset
of
about
this.
the baby moon. I'm like, if you're going to complain about money, I'm like, then put some of that baby moon money towards services postpartum-wise. And I think people make assumptions about the help that they're going to get too during that 4th trimester in their first year, and they think all these people are going to step up, and it doesn't work out. And that's another mental health component, is that they feel failed by the supposed village.
Right, and there's a lot of being talked about, and I love the memes that are like, where's the village? Where am I supposed to find it?
Right.
Not everybody has a built-in support network, and so being able to afford the complementary care systems, it's a privilege. And so I think, in the U.S. especially, and then you're thinking of 4th trimester, 3 months, many parents are going back to work at that time, and they're not taking good physical care of themselves, they're still not sleeping, you know, and it all feeds into our physical and mental health.
Their partner can't keep up.
Yeah.
They simply just can't keep up.
Right.
Because it's crazy. Okay, did you have something to add along the lines of referrals?
Yeah, so basically it's the same thing. It's like word of mouth. Like, oh, I heard about you. I heard you're good, so we'll come see you. And one of my friends went to pelvic floor PT, so I thought I should go. I mean, I've been doing this for 23 years, and it's mind-blowing that we don't have a consistent referral of every single OBGYN patient. It should just be protocol.
It should be standard.
Because it's that way in other countries.
Right.
In the hospital, outpatient, the process starts sooner.
Okay.
Okay, so for those maternity patients, those referrals need to happen. And with the young, I mean, right now my gynecologists are younger than I am. And I'm just assuming in residency that it comes up that, you know, these patients should have a pelvic floor referral. And it's not just a physical therapist, there are occupational therapists who are also certified in pelvic floor. And they have great manual techniques and great exercise prescriptions. So I tell my patients, stay open to that, you know, just to start the process. So you're not overwhelmed with all the information. And quite often patients are very overwhelmed in that first visit with me. They get a lot of information in 45 minutes.
Head's gonna explode.
Yeah. So it's a lot. So we wish that we got more doctor referrals and that it wasn't just based on word of mouth in the community, which we're grateful for.
Pausing the perinatal stuff.
Sure.
Pelvic floor issues
Yeah.
aren't just related to pregnancy.
Right.
And what are some of the different types of pelvic floor issues that could develop with anyone?
Right. So like the wait list I had in England, it wasn't just prenatal, postpartum. Definitely not. It was a lot of urogynecological patients.
Okay.
A lot of patients with severe stress, urge urinary incontinence, mixed urinary incontinence, severe cystocele, bladder prolapse, rectocele, rectal prolapse, enterocele, uterine prolapse, vaginal wall prolapsing. So a lot of those patients.
Now those all those different types of problems, do they all come together, or can you just have like one? Or
so when I first started out as a PT in Auburn, Massachusetts, you know, I would have patients in their 80s coming to see me, women's health patients, and they would have urogynecological surgeries scheduled at maybe UMass Memorial, and they would cancel them after 1 or 2 visits with me.
really?
Yeah.
You're a miracle worker.
Well, it's just teaching the right exercise prescription and being patient with the patient. And patients would come off their medication for their overactive bladder, and they would cancel their surgery because they were dry. Their underwear, their pads were dry. And these are women in their 80s. So they got the hang of what to do with their pelvic floor muscle, when to use it and when to rest it so it doesn't over fatigue and get too tired when it needs to work, such as when you sneeze, cough, and laugh, get in and out of a chair, roll over in bed, get in and out of the car.
Exercise.
Now,
Yeah.
do
Yeah.
you see
Walking.
I don't know if correlation's the right word, but any patterns between women who have given birth versus women who have not given birth?
Eventually, they will all come to me.
Eventually they'll all come to you. Okay,
Yeah.
so it's only a matter of time.
It's only a matter of time that everyone is going to have to address their pelvic floor. The pelvic floor muscle group, it's attached to the base of your spine, your coccyx, and to your hips. The fascial tissues spread out to your hip joints. So over 80% of the population is going to have back pain in their life. There's going to be hip pathologies, osteoarthritis, degenerative joint disease. So the pelvic floor muscle is very important part of rehab for the spine and the hip joints, the musculoskeletal system.
Who knew? Well,
So
but
we do, and you know, we'll have women come in with prolapses and incontinence who have never been pregnant and never had children. And when we took our courses, like in our 20s, in our continuing education pelvic floor courses, a lot of us already had a grade 1, grade 2 prolapse of our bladders or our rectums just from having constipation.
Wow.
Okay, and impaired bad body mechanics, lifting, pushing, and pulling, and not remembering to, they're not being told how to use that muscle.
Okay.
Okay, doing basic day-to-day stuff.
Who knew?
Yeah, so you're not, we don't learn about it in physical education class, but I feel like physical education classes have improved over the years. They're doing a lot of yoga, they're doing a lot of mindfulness and stretching. I've met some gym teachers, they talk about the bridging and squeezing the glutes, and all those exercises are gonna help with the pelvic floor muscle and bowel bladder function. So I think people are catching on as to how they can incorporate it.
Well, I also think the whole yoga thing goes back to relaxation techniques and mental health as well. So, I just made the connection while you're both here. But is there anything you wanted to add? Or can I go back to my other
So in
question?
pelvic floor rehabilitation,
Okay,
we want to see referrals from the urogynecologist preoperatively, give the patient a choice to try out the physical therapy for a few months. Okay, and then if things aren't going in the right direction, the patient has a scheduled surgery.
Okay.
And then they can come back and see us post-surgical to continue strength training and working out any scar tissue issues, body mechanic
So it's usually
training.
like a couple of months before they would see any progress? Or?
Yeah, 6 to 8 weeks to improve a grade of strength. So I tell patients, give this a couple of months. It doesn't mean that you're going to see me every day. You're going to be doing something from my home exercise program. So I give patients several attachments on an email the first day I see them, and I tell them to download all my attachments to a PT folder on their laptop or tablet. And for patients who are not tech savvy, I try to give as many printouts as possible. And I repeat myself a lot for those patients who need it. I tell those patients just tape it on a wall, pictures of these exercises. And if it's just one group of exercises, trust me, that's gonna help you. And the exercises are very yoga, Pilates based exercises and all functional positions, standing, lying on your back, and sitting. I have videos of myself doing the exercises too that I give to patients. During COVID lockdown, I had a lot of time at home, so I made a lot of videos.
And I'm sure your kids helped with the videos.
Oh yeah, they're in there. Yeah. So yeah, we tell our patients, we want to see you beforehand, and you're not going to be with me forever. There is a discharge point, and you can always come back and see me again if need be. And usually patients find the right class, or they sign up for something on their own terms, their own time, and not on mine, and they're happy.
Like a class?
Yeah, like a yoga class or Pilates.
I'm like, do you host classes
Right,
too?
or even just going to the senior center and taking a chair yoga class, even a breathing class, because when you inhale and exhale, the pelvic floor muscle is moving as you inhale and exhale with your diaphragm and all your other
I'm
accessory
sitting here
muscles.
like breathing, trying to pay attention to, what's moving.
And we see that a lot with our pelvic floor diagnoses, that our patients hold their breath a lot. They don't breathe. They don't breathe. They can't exercise and breathe and talk and count out loud. So I'm like, as basic as this sounds, we're going to practice this today. And patients are amazed by the difference of these subtle changes.
Wow.
Yeah.
Cool. Going back to, I was looking in here for my notes because I thought it was written down here, but when we're talking about women and postpartum depression, I'm going back to when I had my first child. It's like, how much is the baby blues and just hormonal?
Yeah.
How do you know you cross that line into like clinical depression?
Yeah, that's a great question. What's the difference? What does it look like and what does it feel like? And I think it's important that those baby blues are what we consider the first, 2, sometimes 3 weeks after birth. 80% of new parents will have kind of their hormones are shifting, they're kind of crashing really fast, they're all over their place, there's crying, there's worry. That's kind of
Crying from the child and the mom.
Right. And kind of what we're looking for to see, okay, is this a perinatal mood disorder? And I use that term, that umbrella, because I think it's important to give attention to postpartum anxiety, not just postpartum depression.
Okay.
And kind of when do I want to see somebody, or when do I want to make sure they're getting a referral? Whenever anything feels in excess. So if it's an excess amount of crying, or if it's an excess amount of worry or anxiety, if parents aren't leaving the house, if because of anxiety or depression or worry, if there's rituals being developed, if there's a postpartum OCD that's coming up, that's when it kind of crosses that barrier of if things are not improving. So after that 2 weeks, the crying should start to subside. The worry should right? It should feel, oh, okay, if I was in a pool of a bunch of other moms, this would be a common worry. When I hear my clients that are staying up and checking the monitor, the big question I always ask is, are you able to sleep when baby's sleeping? And that's usually a good indication of where their anxiety level is at. So if baby's sleeping and mom or dad says, no, I can't sleep because I need to watch the monitor to make sure they're breathing, or I have to go into the baby's room X amount of times to check them, those are those flags to me of, ooh, we're getting into this clinical level of, I want to see you more frequently. And so a lot of times I tell clients looking for frequency and intensity. So if symptoms aren't getting better or improving after that 2-week period, or feeling more intense, even if they're feeling really intense after a week, I don't want anyone waiting. Well, it's baby blues, let me give it another couple weeks. So that intensity level. But sleep, anxiety, crying, apathy. So do I want to engage with baby? Am I enjoying when I'm sitting here with my partner? Do I want family coming to visit me? How engaged am I? Those are all really good signs for birthing parent and partner to look for. I think it's important, partners also have a high risk of a perinatal mood disorder. So 1 in 10 non-birthing parents will also have a perinatal mood disorder.
Okay. Wow.
And so when
That's a pretty high percentage.
It is. Yeah, it is. And so typically in my practice, I'm seeing clients individually, but I'm asking all the time, okay, how's your family adjusting? What's your partner like? What's their stress level like? Are they sleeping? So even though I, primarily do individual work, I like to check in on the whole family unit and then provide resources, referrals, make sure the whole family is getting the identified help they need.
Okay. What about parents who may have adopted?
Sure.
Because they did not go through the whole hormonal wackiness, but here's a human, keep it alive.
Yeah, same risk factors. And I think it's important when we look at risk factors for developing a perinatal mood disorder, hormonal changes is just one of the risk factors. So there's psychosocial mood changes, or psychosocial changes, the change in the environment. Bringing a new human is a change into your environment. And I think that's why people get surprised when non-birthing parents can also have a perinatal mood disorder, because they haven't gone through that hormonal change. But the hormones is one risk factor. It's not the only determining factor of a postpartum mood disorder.
Now, would like a family history of anxiety?
So the other risk so the other risk factors that we look at besides the hormones would be somebody having their own previous diagnosis of anxiety or depression, a family history of anxiety or depression, access to care. So we're looking at, does somebody have financial means, socioeconomic factors, age? Younger parents, teen parents are at a higher risk than older. And when we look at it, we think of, okay, well, your support network is not as developed and your access is going to be limited. Birth trauma. These are all things that can increase, I use that term birth trauma for what did the client experience? What did they feel? So it doesn't have to be this big T. It can be this big trauma but it can also be these smaller traumas. How supported did I feel by my medical team? How much was I heard? How much was my pain acknowledged or managed? Was I going to my OB and saying things are hurting and they're telling me, well, that's just normal, you just gave birth? Right? So all of these little risk factors, which is why I think we know more. It's not just those hormones.
Speaking of...
No, I just remember at 9 months after I had my first child, I would just remember being wide awake through the whole night, and I just started to cry. I'm like, I just need to go to sleep. I have to work tomorrow. And that's when I went to my primary care, not the OBGYN, and she put me on like 10 milligrams of fluoxetine.
Yeah.
And she's like, when you're struggling, you can take this. And it worked.
Yeah.
But it was 9 months. Like, everyone thought I'd be in the clear of any issues.
Yeah.
But, like, I'll never forget that night because my husband was like, who are you?
And I think that's a really excellent point to bring up, is that when we're looking at when does a postpartum mood disorder develop, it's not just right after birth. And so that postpartum period we really consider is anything, those first 2 years after birth, we would consider, oh, this is it. So we look at when did your symptoms start. So if somebody comes to me at 9 months, but I'm not seeing them till, 3 or 4, but it really started, that was an undiagnosed postpartum mood disorder. And when we look at kind of those shifts that happen, so going back to what our cultural expectations are, moms are given, maybe 12 weeks of a leave, paternal leave too. And so there's this big transition shift of, oh, now I'm going back to work. So now I've added in this psychosocial stressor of change. And so sometimes I'll have parents that say, oh, I did really great after birth, but then, the night before going back to work, I couldn't sleep. And for the next 3 months, I couldn't sleep again.
Oh, wow.
Right.
Yeah, this is a tough culture, the American culture. I have friends who are doctor moms, physicians who are moms, who've been called in during their short-term disability. Within a few weeks they're getting called in to help out at the hospital.
Yeah. And especially like our residents, our like resident physician, new parents, it's really hard. The pressures we're putting in that program, and then the leave, it's just non-existent, which I think goes to this larger support system, that village, right? And at 3 months, many babies aren't sleeping through the night, and so parents aren't sleeping fully through the night, yet they're going back to a 40-hour plus week job and expect the expectations.
To juggle because
on-call hours,
shift work. If moms who are nurses and people who work in the medical field that are working, different hours, which already impacts sleep.
Right. And like we have more humans and more people in the country of the United States. Like, we compare our country to other countries like Denmark and these other countries that keep showing up on Netflix. And I'm like, we do have many, many more people to take care of in this country too. So I don't know if it's just we're out of control. We just have so much to manage, and it's like, how do we do this?
Right. Well, and I think in Denmark is a great example, and I know it's talked about a lot in documentaries and the news, but also kind of as a culture, what they value and where they put their priorities. So when we look at some of our neighboring, countries that have a full year of maternity or paternity benefits.
Germany, 2 years if you have twins.
Yes.
That's what I was told from another German.
Wow.
2 years.
Wow.
So I gave myself 2 years.
Yeah.
I'm like, I worked in England, so I mean, technically, I'm practically German.
Right?
So.
But if you think of, wow, my sole job right now is just to learn how to take care of this human for the next year, and that's all I have to focus on.
Yeah.
What a different mindset than our go, go, go culture that we do have here, where slowing down and breathing is not prioritized.
So with both of your areas of specialty, I actually wanted to bring up the point that you just did about multiples. What have either of you noticed a difference between singleton birthing and multiples?
Yes.
Either in the physical or the emotional.
Sure. Well, I think sleep, number one.
Yeah.
Right.
It's insane. Yeah.
I
thought having premature twins was the worst thing in the world, but all my friends who are physicians said that, but they're in the NICU getting on a schedule by the nurses. The nurses are putting them on a schedule, and my twins came home
on a schedule.
Yes. And as devastating as it was that I gave birth early because I had preeclampsia, which is another huge issue. Eventually it worked out. I had them on a good sleep schedule, and it really helped a lot.
Because I'm just thinking about that, it's like sleep when the baby sleeps. Well, if you have more than one, they're not going to sleep at the same time. And how do you feed both
I
of
felt
them
like
at
the
the same
nurses,
time?
and I have to say, my babies went through Winchester Hospital and Tufts, New England Medical Center, and I have to say the nurses were just outstanding at prepping me, you know, for those nights. They told me what my goal was going to be. They're like, you're going to get that baby to sleep at midnight to 6 o'clock in the morning. You are aiming for 6 hours straight of sleep. That is your first goal, and we did it.
That is my goal for my clients, and I talk about that 12 to 6, and so I talk a lot about shift work. Yes,
oh
and the shift work with parents. I want both parents getting 6 hours uninterrupted, and so I think that's the key is uninterrupted sleep. So when I have, you know, my mom's come and, yeah, I slept for 8 hours. I'm like, really? When did you sleep? Well, I slept for 2 hours, and then I was up for an hour feeding, and baby was having trouble. But then I went down for another 2 hours, and then I woke up and I was anxious. But, you know, if I count them all together, I got 8 hours. I say, no, we want 6 straight hours of sleep.
Well, I think that has changed, the whole 6-hour thing. Yeah, are we talking like with newborns, or are we talking with, you know, after 9 months of?
Well, this is it, and I'm meeting more and more moms who are only getting maybe 4 to 6 hours of sleep. They're working full-time jobs, and they're running around with the kids and their activities. And, you know, that's not how we practice. We tell our patients you should be getting close to 8 hours of sleep.
Well, the reason why I'm asking is, like, when I had given birth, the consultant, the feeding consultant, was telling me I needed to wake up that child every 2 hours.
Well, I think
my child did not want to wake up every 2 hours.
Well, and I think every every family is going to be different, and every baby is going to be different. So baby needs are going to be different
so
too.
I'm like, oh, the specialist.
Sure. Right, and I will tell all of my clients, I know, I'm sitting here telling you that 6 hours is my goal. It is not realistic in those early days. You're waking to feed, you don't know what you're doing, it takes a long time. So we know that's not realistic. But then if we can't get it overnight, what does your support system look like so that you can rest? And even if you're not sleeping during the day, how are you resting? How are you not feeling like I have to do all the laundry and I have to do all the cleaning because the baby's finally napping? Right, and I have to eat. Like, I just want my clients resting. So this 6 hours is a goal.
Okay.
But it is attainable, whether it's working with a sleep consultant when the baby gets a little bigger, whether it's doing, you know, shift feeds with partner. I have a lot, you know, a lot of different feeding options are out there. And so if my moms will say, look, you know, it's really important to me that I breastfeed, great, can we pump during the day so your partner can do a bottle overnight and you can sleep? Or can partner just bring baby to you so you are not getting out of bed, right?
Okay.
And having a clear verbal conversation so everyone's on the same page and we're not resenting each other, all that.
And holding space that this is temporary. It is a temporary, hard time, and it will change, right? Baby will go longer between feeds.
And as soon as you get used to the schedule, it's going to change into something else.
Right. But hold that, you know, and I tell all of, you know, nothing good comes into your mind between the hours of really 1 and 4, right? 1 and 5. Yep. That is not when our clear, cohesive thoughts are coming up. We're catastrophizing. We are thinking of the worst case. We're angry that our baby is not going back to bed when all we want to do is sleep.
You're exhausted.
You're exhausted. And so, and that is the first line.
I'm just laughing because, oh my gosh, that is so real.
Right. And it doesn't end, right? It doesn't end when they're little. I mean, I was up the other night catastrophizing about my very not, you know, newborn child in the house. So I think, and you know, I think we have to really normalize. This is something all parents go through, but if you're going through an extended time, we want to be able to make changes.
When you, when we were talking about that fine line, as well as you had mentioned, like younger parents, I'm thinking the opposite, because when I had my kids, I was advanced maternal age, and it seems, I don't know whether I'd call it a trend, but it seems like a lot of women are having children later in life. How has, not necessarily has that impacted you, but what differences have you seen because of this trend?
I feel like it worked out better for me to be older. As I'm listening to you and I'm listening to your conversation, I'm just like, yeah, it was probably best that I didn't have children in my 20s. I think I was just in a different place. I was really about my career. I was still learning a lot about myself. I just feel like I was smarter.
You know more. You
I
have
was
more lived experience.
I really was more knowledgeable. I don't know if things would have gone as well for me, if I was younger having my kids. Even though it is hard, you know, there's cons to having kids later in life. I just feel like I knew more. I was more in control, maybe more verbal, and able to speak up for myself and advocate more.
But physically, how does that?
Yeah. I mean, if you're not doing the right thing going into a pregnancy later on in life, if you're not taking good care of yourself, not just with your exercise, but also your diet, you're going to struggle in that pregnancy and postpartum and recovery. It's going to be tough. And that's why I brought some information here. I don't know if you want to just say the title of that book.
How Healers Heal. Lifestyle Medicine Physicians Transforming Healthcare and Their Own Health.
And then the
I
doctor,
don't know if they can see that. They can see that.
Dr. Shilpi Pradhan, I'm probably not saying her name correctly, but one of the doctors who I work for, Dr. Supriya Rao, she's a gastroenterologist, and she's an obesity medicine board-certified physician.
Oh, wow, okay.
I work for her in North Chelmsford at Integrated Gastroenterology Consultants.
Okay.
And she writes about how, you know, gut health and lifestyle medicine. So she talks a lot about that, and just not how it's going to affect you physically, but mentally and emotionally. So again, lifestyle medicine.
Okay.
So she's bringing that all into what she's writing in that book. I just bought it. I have yet to read it. I just bought a couple of books to share with friends.
Cool.
I'm excited. I was looking at it. It looks fantastic.
So it's doctors talking about themselves, and you know, even Dr. Rao, you know, going to med school, she said recently, you know, she wasn't taking the best care of herself at certain parts of her life, and in this journey and education and practice, she's learned to do better for herself and help others. So that's something that I'm sharing. And then next to you, Linda, is the Pivio book. So in the practice that I work for, Integrated Gastroenterology Consultants, we have a Pivio program. And E is the recipe book, and Write is a journal. So that's part of my homework assignment.
Homework? I just have a newborn kid. How am I supposed to do homework?
So with diet, so that's the thing with like
Oh my gosh, it
prenatal
really
diet,
is like
postpartum.
Blank.
Yeah. So, you know, in this program, so this Pivio program is reimbursed by health insurance. So my health insurance pays for this program, and I have 2 virtual meetings a week with the nurse practitioner, Gina Kelly, and Dr. Supriya Rao, for 30 minutes in the evening. And we go over the program and some of the goals and objectives with everyone else who's in our group, our cohort. And we go over recipes to what to buy from the grocery store, what to get rid of from your kitchen and your pantry and cabinets.
That would pretty much be
and
everything in my
what to stock
kitchen.
up on in your home, and then try to follow those recipes. But this program isn't just about food, but it's also about stress management, mindfulness practice, and exercise, trying to get that 3 to 5 times a week of cardiovascular exercise, some strength training and stretching. What we know, what we're supposed to do, but just how to do it and how to get it done. So this has been a really good guideline, at least for myself, and it's really important. I felt going to a nutritionist during my prenatal periods was awesome. It really got me back on track, just to think about what do I need to buy at the grocery store, what do I need to have at home and nearby, and less of what do I need to stay away from to give me the energy I need. You know, to get through the day and enjoy
caffeine
my
and
baby.
chocolate probably weren't the best
the
combinations.
sugars. And when you're tired, you do crave a lot of the bad foods, a lot of the bad snack sugars. So that's why it's good to have a guideline. And we have a nutritionist in our practice. But this program has been really great, this Pivio program. So I just wanted to share that.
Cool.
That it's really important for prenatal and postpartum to address the diet and fluid intake habits, especially if you are breastfeeding. You're losing a lot, so you have to make sure you have a nice storage for yourself.
So thinking, you know, stream of consciousness here with the food, do you need to direct yourself more toward organic plant-based or?
This is a plant-based program. Pivio is plant-based.
Okay.
And being an Irish Canadian girl, I grew up with a lot of meat and potatoes. And we
yeah.
definitely had our vegetables and fruits, but not like my friends who were Italian and Greek. They had amazing, when I'd go to my friends' houses, they just had amazing recipes. I mean, it was just nothing what I would see in my home. And I never felt deprived, but this is different. Like I'm using ingredients that I can't even pronounce. I'm going into aisles of the supermarket that I've never walked down now.
Okay.
I'm just putting stuff together. And I said to my nurse practitioner, Gina Kelly, that I'm like, this is just hard work. I'm like, I've got the kids here. I'm trying to put this
do
nice
the kids
meal.
eat this stuff too?
The kids are trying it. My twins are good eaters, so
Wow, okay.
yeah. And then so yeah, it's hard, but like we discussed in our last meeting, that it's going to get easier. I'll get used to grabbing things in the kitchen and putting things together. I won't always have to look at the recipes. I'm going to have a working knowledge of recipes.
Okay.
And for this beginning of Pivio, I had to do a 5-day fast, which was no animal products. So no chicken, no
wow.
salmon, no eggs,
Yeah. Dairy?
no dairy.
Because no product.
So no
Interesting.
animal products. It's like
Yeah, and I thought, part of the reason that I'm also doing a program like this and I'm sharing it with my patients and everyone I know is because I have a lot of GI cancers in my family and in my heritage, especially my Canadian relatives. And I've had a lot of close friends die of GI cancers recently. I've had a few,
I'm so
and I'm
sorry.
only in my 40s, so there's never a good age to die of it.
Right.
But it's like, what's going on? Like, you just ran the Boston Marathon, you did a triathlon, and now you have pancreatic cancer. How does this happen? So this is a plant-based diet, and I asked Dr. Rao, I'm like, I thought salmon was it. Like, if I ate salmon, I'd live forever. But she said, but what about what the salmon eats? Salmon eats algae, the seaweed, so why don't you choose the seaweed, put that in your salad, put that in your couscous, and mix that in. So that was like a big deal to say, goodbye to salmon for a little bit, but I'm okay because I have the lentils and the legumes. I have other, foods that are fortified with all those minerals and vitamins that we need. So it's different. It's a very different approach. I don't think I'm going to say goodbye to salmon forever. I am Irish. I like my fish and chips. So I will probably have my salmon on
maybe
Fridays.
not deep fried all the time.
No, but I'm going to have my salmon. So, but yeah, this is a good change, and it's supposed to, obviously, nobody wants a GI cancer. I work for a gastroenterology practice, and that we don't want to see our patients go through anything like that.
Well, I'm also just, the uneducated me thinking about this and all the GMOs and all the chemical enhancements that they're doing to make food look prettier and last longer. That's got to be affecting us as well. So
yeah, I think that's a big,
that's a whole
part
other
of it. Yes, and just it's like this is work to really be at home and prep your food with all these activities. We're running around with our kids and we have jobs. This is work. So I guess with practice you get better, you get smarter at it, you get faster at it. But I also think about pollution in the air too. That has to be a factor in why people are getting any cancer, but also the GI cancers. I feel like that is definitely still a component. So I'm with those groups, those groups too.
All right, jumping around, back to the whole pregnancy pelvic thing, because food is important.
Yeah.
What about, and I think your website touched upon a little bit about pregnancy loss. So nobody expects it, nobody talks about it. But there's still an emotional component and there's still a physical component as well. So how does that get integrated into your expertise?
Sure. So my practice, I specialize in perinatal loss and infant loss. So many of my referrals and many of my clients are within the loss community. And it is, kind of this taboo of, well, am I really postpartum because I didn't get to bring home a live baby? So do I really need to do all of these complementary services? And it's very painful, not just the physical transition and the physical recovery, but the emotional recovery of imagining going to specialists and asking for referrals to heal this part of your body where such a deep wound occurred. But yes, my pregnancy loss clients are postpartum too.
I try to talk about the future too, like, once they have a conversation with their OBGYN about when should we start trying again to get pregnant, we start, talking about the future, and that makes the patients feel hopeful. Like, this is good, I'm here, I'm getting stronger again physically, and I need to get stronger here. So getting stronger here is going to help me get stronger here. There's going to be a connection. So I do like seeing patients when it's the right time for them to take on coming to an appointment and doing the exercises. I leave that up to the patient and the doctor, and obviously, hopefully, they're on board already with someone like yourself.
Oh, I found the question about the line of clinical versus. How has, we only have like a couple minutes left, so I don't know if we've addressed this or not, but I do want to kind of bring attention to it. How does society's attention to mental health over the past few years, even like through COVID, I think that's really what raised up the mental health awareness. How has that impacted either of your
Sure. The need is high, and the demand is high and the supply is low. And so I think, the past couple of years, there's been a lot of attention. I think there's still a lot more work that can be done. Maternal suicide is one of the leading causes of a postpartum death. And so we're talking about it, but we're not talking about it enough. Being able to find a specialty provider, I think, the one advantage of COVID, if we have to say there's advantage, is many of us, got thrown into telehealth. And so I think, which has expanded the access. And so even within my practice, I've never did a Zoom therapy session before, before March of 2020, and now, a good portion of my practice clients still prefer Zoom. So I think there's the accessibility of it. But, I think our country has a long way to go to, support maternal mental health and get people in the door and have enough quality trained providers to provide
getting
services.
People in the door to get help, or getting people in the door to study to be the providers?
All of it. All of it. I think all of it is so important and so needed. And so I think we're making headways, and I think there's been a lot of really great political action in, reproductive rights and maternal mental health. There's the National Maternal Mental Health Hotline, which just launched last year. I don't have the numbers off the top of my head, but it was incredible, the volume that they do on a monthly basis. So the need is out there, and people are calling. But even if you look at, we live in Massachusetts. We have access to fantastic care. There's no inpatient or perinatal specific mental health treatment center in our state.
Right.
Really?
So the closest, what we call an IOP, an intensive outpatient program, or a partial hospitalization, is women and infants in Rhode Island, Providence. It's a wonderful program. I've had many clients that I refer.
It's kind of far.
But it's far. And so even in this state,
room for improvement.
Of course. And, Rhode Island's program, there's a handful across the country. And even people who really do need that inpatient psychiatric care, there's very few places that specialize in maternal mental health. So we have a long way to go still.
But at least we're talking about it.
Yeah, I've talked to some nurses too who think we should have like a service, like a home health service, where we have like an aide come in during the day, maybe an aide at night.
And I do have to give a plug, Jewish Family Community Services. You don't have to be Jewish to access their services. They have a Visiting Moms program. It's free for clients. I refer a lot of families there, and it's wonderful because it's that visiting nurse. It's someone coming into your home to check on mom, check on baby, check on attachment, and they stay for a couple months after birth. But that's the minority, not the majority.
But you know what? We're out of time. So
thank you.
We're going to have to continue this conversation again later.
Thank you so much. Thank you so much.
Thank you both for joining us, and I hope everyone at home has learned a new appreciation and awareness of how important the mind-body connection is to stay physically, emotionally, and mentally healthy. So thank you for tuning in. I'll see you around town. Good night.